mitigating the angiotensin like 2 and TL4 natural factor kappa beta expression. You can start, Dr. Mohamed.
Okay, thank you for your presentation. I'd like to share with you this piece of paper. We are looking at the effect of angiotensin 2 receptor blockage on diabetic nephropathy, and that is what we know. But what we don't know is the new pathway involving angiotensin like protein 2, toll-like receptor 4, and nuclear kappa P expression. And you can find this paper in Molecular Biology journal, which is published last August. Diabetes is associated with metabolic and hemodynamic alteration contributing to diabetic nephropathy. Hyperglycemia induced nephron dysfunction leads to inflammatory cytokine injury to podocyte and apoptosis. Hyperglycemia and angiotensin 2 induce nuclear factor kappa P activation with subsequent toll-like receptor 4 expression modulates immune response and cytokine release in diabetic nephropathy. Diabetes-induced inflammatory processes are associated with integrin and alpha-smooth muscle actin expression and glomerulosclerosis. Angiotensin-like protein 2 is a vascular growth factor with pro-inflammatory properties promoting vascular destabilization in diabetes. In vitro, in hyperglycemic knockdown, angiotensin-like protein 2 decreased collagen 4 and fibrosis, and in vivo, angiotensin-like protein 2 knockdown ameliorated diabetic nephropathy via inhibiting the toll-like receptor 4. Clinical trials have so far shown inconsistent results for using angiotensin blockage to decrease the risk of progression of albuminuria in normotensive patients. That's point number one. And point number two, that clinical studies start when the disease is already started, with established diabetic nephropathy as a therapeutic tool. So there is no studies investigated early valsartan blockage before the establishment of diabetic nephropathy. So this study follows up and compared the difference of the early and late intervention by angiotensin 2 blockage, valsartan testing a novel pathway involving renal angiotensin 2, angiotensin-like protein 2, toll-like 4 receptors integrin nuclear factor kappa P and inflammatory cytokines on the progression of diabetic nephropathy. And to achieve this goal, we need to do a complex scheme of methodology involving two experiments. Experiment one, when we start valsartan early in this process, starting after the first week of just induction of diabetes before the establishment of diabetic nephropathy. And we follow a group for 4 weeks and we sacrifice rats, and we follow a group for 8 weeks and sacrifice rats, and for 12 weeks and we sacrifice the rest to see the temporal changes in both the renal contents of these inflammatory biomarkers and renal histopathology. While in the other experiment, we induce diabetes, we let the period to full-blown picture of diabetic nephropathy, and we do treatment at the end of the 8th weeks, and we do sacrifice at 12 weeks. So with this methodology scheme, we have 4 groups: the vehicle group, valsartan control, diabetic control, and valsartan treated groups. And the difference, which is termed renoprotective group or renoprotective experiment, where we start valsartan early, starting from the first week. And in the xenothrombotic group, we start valsartan at the beginning of the 9th week. And the study parameters, we covered all aspects in the process of diabetic nephropathy. As an overall function of kidney, we do creatinine and urinary albumin excretion rate. For the filtration barrier integrity, we do urinary nephrin and KIM1 levels. And for inflammation, we tested the renal content of nuclear factor kappa P, angiotensin-like protein, and integrin and toll-like receptors. And of course, all the downstream activation for the nuclear factor kappa P involving interleukin-1, 6, TNF-alpha, and MCP-1. And for fibrosis, we do the renal measurement for angiotensin 2, tumor growth factor beta, collagen 4. And as a marker for cellular proliferation, we do alpha-smooth muscle actin. And as a marker for increased matrix deposition, we do collagen 4 gene expression. And of course, we didn't forget to do apoptosis, and we do renal histochemistry with the apoptotic pro markers caspase 3. So our result was the following. As we see from this, the diabetic control with valsartan control, valsartan treatment was effectively decreased proteinuria, and that was expected. But what we note here is the effect of valsartan increases with time. It is here twofold, and it increased at 8 and 12 weeks to be fourfold rise in the renal effect. And the inhibition in the renoprotective group, or the magnitude of decrease of urinary albumin excretion rate, was much higher in the neuropreventive versus the renotherapeutic group. And when examining the effect of valsartan on urinary, nephrin, and kidney injury molecules as a marker for filtration barrier integrity, as we see in diabetics, there is increase in their excretion compared to vehicle in both sides, and while comparing both protocols, the neuropreventive shows much decrease in their contents in comparison to renotherapeutic groups. Again, here when testing the main study hypothesis, as we see all inflammatory marker, the nuclear factor kappa P, which is the key regulator for all inflammatory cytokines, angiotensin-like 2 protein, are higher in diabetic versus vehicle, higher diabetic versus, and also here the 12 receptors and integrin all are higher in diabetic versus against vehicles. And both renotherapeutic and renopreventive protocols show degrees of their levels with favor to the renopreventive against the renotherapeutic protocol. And when we are looking for fibrosis, that receptor beta and collagen 4 all are decreased, and again in favor for the renoprotective versus the renotherapeutic protocols. And when we are looking for the markers of cellular proliferation and matrix proliferation, we can see it so also both are comparable results when seeing Western plot for both groups. Okay, what about the histopathology? As we see here, in vehicle group, that is the normal histology of the kidney, the normal glomeruli, starting from 4 and 8 weeks. We starting there is obliteration of the vessel with increased matrix deposition, and there is a full-blown picture of diabetes. And when we see here in Mason in this blue color, there is fibrosis. So we have well-established fibrosis at week 8 and week 12, and that is in diabetic control. Regarding the valsartan control, as we see, it is clearly there is different pathology, and we can see from this blue card, there is no blue card here in Mason trichrome and valsartan treated, reflecting the effect of valsartan in decreasing fibrosis in histopathology. And even the renal histopathological scores, which involves 4 points starting from 0, 1, 2, 3 for tube interstitial components, and again for the glomerular component is 0, 1, 2, and 3, and the renal score is the sum of both. There is decrease in the renoprotective protocol. And again, that is the renotherapeutic protocol. There is also decrease, but as we see here in valsartan group, there is fibrosis. You are giving valsartan late in the disease after fibrosis has been established already, not as such. And here, the immunostaining for caspase 3 with an increasing pattern for immunostaining regarding to the fecal group. Okay, in valsartan, as we see, there is decrease in the amount of the immune staining. So, in conclusion, the current study suggests that early inhibition renoprotective with angiotensin receptor blocker valsartan is better than the late inhibition renotherapeutic, which leads to initiation or progression of diabetic nephropathy by blood glucose independent mechanism. Early inhibition of angiotensin 2 in diabetes showed to decrease the renal injury evidenced by decreasing urinary nephrin and kidney injury molecule 1. The decrease in renal angiotensin 2 is accompanied by a decrease in angiotensin-like protein 2, toll-like receptor 4, alpha-smooth muscle actin integrin expression, and consequently the inflammatory state leading to fibrosis and the whole renal injury process as indicated by a decreasing in urinary albumin excretion rate and blood pressure. Thank you.
Dear doctor, your time is up.